Okay, so today we are going to understand about the atrial fibrillation, and this is going to be a very high topic for the examinations, and also it is the most common sustained cardiac arrhythmia in the clinical practice. Okay, before we dive into the ECG findings, first let us understand what happens in the atrial fibrillation. Let's have a broad view of it. Okay, so we have this SA node which fires, and then the conduction impulse reach to the atria, then they contract in synchrony, and then to AV node, then finally to the ventricles, and both ventricles also contract in synchrony. So in atrial fibrillation, what happens is that the synchrony is lost. What happens is that multiple small wavelets are formed, and sort of the atria don't contract at a all the atria cells don't contract in synchrony, and this causes sort of atria just to quiver, and this quivering causes an inefficient contraction, and this causes the loss of that atrial kick, sort of the 25% or 30% of the blood that is entered in the ventricle that produces that S4 sound. So that is lost in the atrial fibrillation. And two kinds of patterns in the ECG basically we see, because multiple wavelets are formed, so we can imagine that there are multiple depolarizations, and it's not hard to imagine if there are multiple sort of depolarization. So there would be a different kind of small uh, F waves. We call these F waves, and these are called as the fibrillatory waves because there are multiple small deflections. But even smaller deflections that are not visible, usually these are called as plane oscillations. And so two kinds of one which have F waves, that are the fibrillatory waves, and the other ones with the oscillations or oscillatory waves. Okay, so let us define the atrial fibrillation now. Atrial fibrillation is rapid, chaotic depolarization that involves multiple wavelets of depolarization, as I've already stated, that causes the production of F waves or oscillatory waves. And the rate of the atrial fibrillation of the atria particularly is 400 to 600. Okay. Now the ventricular rate is about 100 to 180, and we can go into the detail that why ventricular rate is 100 to 180, and that's simple because you must be aware of the AV node compensatory pause, that AVN has to undergo a certain amount of refractive period, and the impulses that are arrived at AVN during this time are blocked, and this causes the less amount of the ventricular rate in the uh, less amount of ventricular rate in the atrial fibrillation. And you can also recall that same concept is there in the atrial flutter, but there is some ratio in atrial flutter that 2 is to 1, 1 is to 1, 1 is to 1, 3 is to 1. Okay, and that topic is for some other day. Okay, let us see the types of the atrial fibrillation, and this classification is from the AHA, that is American Heart Association, and 2014 guidelines. I've included the link in the description. Now, this classification is based on the duration. Now, what is paroxysmal? Paroxysmal means something that is for a moment or for some short period of time, and this one usually goes away within a week. Within a week, okay. Now there is something which we call persistent AF, and when this AF lasts for greater than 7 days, it's called as a persistent AF. When the persistent AF lasts for greater than 12 months, it's called long-standing and persistent AF. And finally, a stage arises when the patient and doctor decide not to further treat this AF, that is, not maintain the sinus rhythm, and this is called as permanent atrial fibrillation. Now, one of the mechanisms by which the persistent AF induces the fibrosis in the atrial cells, and thereby inducing the tissue heterogeneity, which we are going to see in a moment. That the theory behind it, there are many, but one of them is the calcium overload that induces stress, and it progresses to fibrosis. Okay, so persistent AF causes calcium overload that progresses to fibrosis. So now we are ready to understand the hallmark findings of the ECG. So basically, there is presence of Afibs, as I've already stated, because of multiple wavelets of contraction. There are too many small depolarizing waves, and you can see over here that there are F waves, something called F waves. But we also have something called as oscillatory waves when these waves are very small, so uh, they are not visible, and they are called oscillatory waves. Now, it may be also seen as the absent P waves, absence of distinct P waves. As you can see, there is no P wave over here. So we can say that absence of distinct P waves is also a feature of ECG of the AF. Now, last thing is that they are irregular rapid ventricular rhythm. Now, this is something which you should be aware of, because refractory period of the AV node, recall, it is not regular. It is actually dependent on the vagal stimulation, respiratory centers, and emotions, exercise, and even on the partial penetration or incomplete penetration of the impulses in the atrial walls. So all these things affect the AVN conduction, and that's why there is irregular ventricular rhythm. Okay. Now, very important to understand is differentiating between the atrial flutter and the atrial fibrillation. Now, atrial fibrillation is in when there is irregular beat, the atrial beat irregular, and the rate is very high. It's around 400. We have already seen 400 to 600. Okay. In flutter, what happens is that yes, rate is high, of obviously, but the rate, the rhythm is regular. Okay. So this point is to be remembered, that in atrial flutter, the rhythm is regular, while in atrial fibrillation it's irregular. Okay. You can remember it by seeing the term IR in the name, so you can say that IR represents irregularity. And second thing, that uh, I've already told you that there are some ratios, that 4 is to 1 beat, 2 is to 3 beat, 3 is to 1 beat, okay, in the atrial flutter, something which we are going to see some other day. Okay. Okay, so one of the important phenomenon we have to discuss is the Ashman's phenomenon. Now, the idea behind the Ashman's phenomenon is that normally in the no, what happens in the atrial fibrillation is that AV node doesn't allow all the impulses to pass through, and this in turn causes some once long RR interval, and this long RR interval, what it does, when it is followed by a short RR interval, and I'm not drawing perfectly, but important thing is concept. So long RR interval followed by your short RR interval. During this phase, first phase, the right bundle branch is not recovered from the refractory period, and during this time when this impulse enters, this appears as a right bundle branch block. And recall from the bundle branch video that there is some blocked, can you remember William Marrow, W shaped in left bundle branch block in the lead V1, and M shaped in lead V6. Then in Marrow, William Marrow, Marrow stands for M shaped in V1 and W shaped in V6 in case of the right bundle branch block. And if you have not seen that video already, please view that by clicking the card above. Okay. So let's see what I've written in the slide. That is that Schmann's phenomenon is when a premature supraventricular beat occurs before the right bundle branch has recovered from refractory period. This causes the QRS premature beat displaying a right bundle branch block, and in some complicated terms, we can say that QRS complex that follow a short RR interval preceded by a long long RR interval. Okay, so long RR interval followed by short RR interval. Okay, this is the basis of the Ashman's phenomenon. Now we will see briefly about the risk factors and some symptoms, treatment, diagnosis of the atrial fibrillation. Now, before that, one of the important thing is that atrial fibrillation is common in case of the WPW. That is, it's about seen in the 20% of the patients. And another important fact is that digitalis and calcium channel antagonists are contraindicated in the these people, and that's because these agents selectively block the conduction through the AV node. And can you imagine what would happen? Yes, it would accelerate the conduction through the accessory pathway, and obviously this would potentiate the other symptoms. Okay, so digitalis and calcium channel blockers are contraindicated in case of the atrial fibrillation with accessory bundle problem, like in the WPW or Wolff-Parkinson-White syndrome. Now, the other risk factors include high BP, coronary artery disease, or valvular diseases, and all these are the cardiovascular risk factors. While in the non-cardiovascular risk factors, we have obesity, diabetes, and excess of alcohol consumption. Okay. Now we are also going to look at various theories and some basic rules that are there to explain the atrial fibrillation, that why atrial fibrillation occurs. Okay, so one of them is tissue heterogeneity, and the idea behind this is that cells, once they undergo some kind of stress, let's say they have undergone MI or something related, some amount of any amount of or any damn stress that has caused the atria to stretch, the atria to lose its different properties. So these cells have different electrical property. For example, one of the cell would have fast conduction while other cell would have slow conduction, or one of them may have slow refractory while other one has fast refractory. So this causes the lack of synchrony. Okay, all these things promote to the lack of synchrony behavior, and that again, of course, promotes to the atrial fibrillation. Okay. So the other theories are the multiple wavelet theory. In this, normally we have this one wavefront that is from the SA node, and this wavefront arises, and no, everything goes normally. But in multiple wavelets, there are many small epitop foci, and from these foci, there are various small amount of depolarization, and that promotes multiple wavelets, and that causes multiple depolarization, leading to atrial fibrillation. Now there is something different, that is automatic focus theory, and people believe that there are some cells near the pulmonary vein that have some different conducting property, and they are capable of initiating atrial fibrillation. Okay. Now the symptoms for the atrial fibrillation, and obviously you can imagine that there is loss of the atrial kick, that is that last 25% or the 30% inflow, which is that 25% 30% inflow from the atria to the ventricle. So obviously those people have lost that extra amount, so this causes a general fatigue. Then we have dizziness, because yes, the ultimately the less amount of blood is reaching, that blood is actually stagnant, or sometimes may also lead to formation of clot because of the stasis or the stagnant blood. Then we also have shortness of breath, and because the blood moves back, you can imagine that when blood is staying in the atria, where does it go back? It goes back to the pulmonary circuit. Then we have sometimes also palpitations. Okay. One of the important complications of atrial fibrillation to bear in mind is that is stagnant of blood. Now the atria sort of quivering, and this is leaking. The blood is not moving rapidly, and this causes the stasis of the blood, and that stasis can lead to clot formation, which can go there in the brain and cause stroke. So can you recall the Virchow triad? Uh, oh, yes, excellent. Stasis, hypercoagulability, and the vessel wall injury. Diagnosis of atrial fibrillation is based on ECG of the persistent AF. Then there is something also called Holter monitor, which measures the 24 to 48 hour uh, sample of the ECG, depending upon what's the requirement. Okay. So finally, let's see the drugs or the treatment in the atrial fibrillation, and we are going to control the rate. Then we are using the calcium channel blocker like verapamil or beta blockers. Then as antiarrhythmic agent, we are using amiodarone, procainamide, arbitrary and flecainide. Then in the anticoagulant, to prevent the clot formation because of the stasis, we use vitamin K antagonist like warfarin. Then oral anticoagulant like dabigatran, rivaroxaban, and also antiplatelet agents like aspirin and clopidogrel. In the surgical methods, we have radiofrequency ablation, and what is in the ablation? Usually done in case of the AVN. So what happens is that we block the conduction via the AVN, that is AV node, and then we implant the artificial pacemaker. So this has prevented those abnormal irregular beats. Okay.
Then we have this called something called maze procedure. Now we form some kind of maze that you have seen in the puzzles, and this causes the impulse to move in a specific direction only. Okay, so this specific direction helps to contract the atria in synchrony. With this, we can conclude our lecture on the atrial fibrillation. Hope you liked it, and subs if you loved it. Bye.